All right, you guys. So we're going to be jumping into our next unit here. This is going to be all things trauma. I know that we started a little series, or we got a lecture earlier on trauma and the respiratory therapist's role in trauma, and we were able to talk about some of the chest injuries or chest wall injuries that are associated with that. But we're going to dive into that a whole lot more as we get into more of these traumas that we're going to be seeing. But the first one that we're going to be talking about today is drowning and drowns. So when we talk about drowning, the actual definition is as suffocation and death because of submersion in liquid. So that is the definition of drowning. Again, that is the suffocation and death because of submersion in liquid. When we talk about drowning, there are three different classifications of drowning. There's near drowning, there's dry drowning, and there's wet drowning. And we're going to break those down just a little bit more. And I know that we're kind of getting geared up for the summer season, which is when we tend to have a little bit more incidents of these. It depends on where you're at, depending on when you have more incidents of this, but we'll talk about that more when we get into the epidemiology. So when we break down near drowning, we don't necessarily use this term any longer. It is a antiquated and an outdated term that we do not use very much anymore. But what this is it's a situation in which a victim survives a liquid submersion. At least they survive it temporarily. We do not use this nearly like we used to, and typically now the terms that we use are dry drowning and wet drowning. When we talk about the dry drowning, just kind of a high level understanding, this is when the glottis spasms. So your airway spasms and prevents water from passing into the lungs. These patients typically have better outcomes. Now, when we talk about wet drowning, this is the glottis completely relaxing, and it allows water to flood and make its way into the tracheobronchial tree and into the alveoli. So one of the two types of drowning, whether it's a dry drowning or wet drowning, is a collapse of the glottis. The other one is a complete relaxation of the glottis. And we see two different pathophysiologies that are associated with those, and we're going to break those down right now. When we look at wet drowning, these patients are at risk of non-cardiogenic pulmonary edema. So they have fluid in their alveoli and their distal airways that is not associated with the heart backing up fluid from the left side of the heart. This fluid typically floods and comes into the distal airways. So we see that not only when that glottis relaxes and allows that water into the tracheobronchial tree and into the alveoli, we see the fluid from the pulmonary capillaries move into the alveoli themselves. So we get a movement of fluid, of water from the upper airway, and we see that the pulmonary capillaries, they allow fluid into the alveoli as well. So you kind of get a double whammy when it comes to these patients, and that's typically why they have a lower survival rate than those with wet drowning. And we're going to break those down a little bit more here in just a little bit. But when we look at the alveolar wall itself and the interstitial space, it ends up swelling with all of that additional fluid, and it ends up having no other place for it to go, and it moves into the alveoli. So the pulmonary capillaries are flooded with fluid. That is then the gates, kind of the gates that hold everything together, all of the elastic tissue that holds the pulmonary capillaries together, they tend to start opening their floodgates. When those floodgates open, that fluid from the pulmonary capillaries moves into the interstitial space and the alveoli. So we start to see this fluid that is in the alveoli, not only from the upper airway, but also from the pulmonary capillaries that are washing out any of the pulmonary surfactant that is in those alveoli. So what is pulmonary surfactant again? What does it do? Well, it reduces surface tension, right? And surface tension is what allows the alveoli to stay open. If we had a decrease in surface tension, the alveoli want to collapse on themselves. So what the pulmonary surfactant does is it increases that alveolar surface tension, keeps the alveoli open, and prevents atelectasis. So when we look at wet drowning, not only do we have fluids coming in from the upper airway, we have fluids escaping the pulmonary capillaries and moving into the distal airways. You get alveolar wall and interstitial swelling. The pulmonary surfactant gets washed out, which will increase surface tension. When we have increased surface tension, alveoli want to collapse on themselves, or alveoli start to shrink. So you get alveolar shrinkage. When you have alveoli that collapse, what's our big medical term for that? Atelectasis. So now you have this area, or your entire lung fields that are filled with additional fluid. The pulmonary surfactant gets washed out and it increases atelectasis. Well, what is the system that it's used to help move? That's help move and to eliminate all that extra fluid that's in the alveoli and the pulmonary capillaries. That's right, the lymphatic system. So the lymphatic system will start to increase the lymphatic flow and start to try to eliminate all of that extra fluid from the lung fields. Now, when we look at all of this extra fluid that's in the alveoli in those distal airways, if you have a patient that's spontaneously breathing, they're going to end up with specific secretions. They're going to be frothy. You'll see white frothy secretions. Sometimes when you start to get that impact from the pulmonary capillaries, we have red blood cells that are escaping the pulmonary capillaries that are moving into the alveoli. So what happens when you start to get red blood cells mixed with those white frothy secretions? Well, you can end up with pink frothy secretions. So in severe cases of wet drowning, where you have fluid that fills the tracheobronchial tree, it's typically going to have white frothy secretions. But when you start to get that pulmonary capillary involvement where the red blood cells are starting to flood the alveoli as well, now the color of the secretions will shift to pink. So you can have pink frothy secretions as well. And then a lot of times, what sort of therapy will they get in order for us to protect their airway and to provide positive pressure for those alveoli to open back up? These patients would get mechanical ventilation. So every time that they're getting a breath of positive pressure ventilation, you get airflow and air movement that causes the frothiness of those secretions. So the frothiness comes from air movement in and out of those distal airways, and the white frothy will be when there is not the pulmonary capillary involvement, and you will have pink frothy secretions when you do have pulmonary capillary involvement. The next thing that we really need to look at is, was it clean water or was it unclean water? So when we have unclean water, we're talking about swamps, we're talking about ponds, sewage, mud, we're talking about all of this extra debris that's in the water that the patient was submerged in. So when that happens, there are an increased risk of pathogens and debris and other ick that the patient can aspirate. When they have aspirations of solid materials, that can lead to mucus plugging or a foreign body obstruction. The other thing is it puts the patient at risk for bacterial, viral, and fungal infections, depending on what they're submerged in. Pseudomonas is a very common bacteria that patients can acquire if they have aspirated nasty, unclean water. So we have to be on guard for now aspiration pneumonia, or there's a risk for increasing in pneumonia when it comes to aspirating these foreign materials or these solid materials. The other thing is when we start to get those pulmonary capillaries that start to lose their integrity, now you start to run into conditions like ARDS. And we're going to have a whole unit on ARDS. But when you start to get into that non-cardiogenic pulmonary edema, and it's not the left side of the heart that's causing pulmonary edema, so whether it is this wet drowning or any other condition where you start to get weeping of the capillaries, especially those pulmonary capillaries, they weep into the interstitial space and they weep into the alveoli. Now you have all of these pulmonary units, all of these functional units that are full of pulmonary edema, that the heart is not the cause of the pulmonary edema. So that non-cardiogenic pulmonary edema and ARDS, they are like linked. They are linked. So we need to make sure that we are on top of our game to make sure that we are being very protective when it comes to their functional units when these patients need mechanical ventilation. So just something to think about, to get ahead of, so that we don't go into that vaunted ARDS. Historically, when we looked at fresh water versus salt water, we were seeing that there was a difference in kind of outcomes or looks when it comes to, is the patient submerged in fresh water versus being submerged in salt water. More up-to-date literature shows that it really doesn't matter if it is fresh water or salt water. Initially, your patient's going to be more hypoxemic with fresh water. When it looks at the long term, when we start looking at the long term, essentially you have the same pathologic changes, and you end up with, again, that reduction in pulmonary surfactant. You get alveolar injury, atelectasis, and non-cardiogenic pulmonary edema. So it doesn't really matter if it's fresh water or salt water. You're going to get the same pathologic changes. The only thing that's different is in fresh water, you end up having more hypoxemia initially compared to salt water. So when we look at the wet drowning, pathologic and structural changes, we end up with patients that have laryngeal spasms. So their larynx is going to close down, their upper airway is going to close down and try to keep any additional water from going into the distal airways. They're going to have interstitial edema, alveolar swelling, decreased pulmonary surfactant. We hit the frothy secretions. They're going to have alveolar consolidation and bronchospasm. So again, remember, your body is a phenomenal defense mechanism. What it does is it tries to keep any foreign body, any bacteria, any pathogen from getting into those distal airways. So what it's going to do is it's going to try to protect itself from those foreign bodies from getting any further into the respiratory system. So you can have the laryngospasm up in the upper airway, and then you can have bronchospasm down in the lower airways, secondary to the body saying, hey, I do not want this fluid getting any further. When we break down the etiology or the cause and the epidemiology, typically this takes place when we look at fatal drownings that are unintentional per year. We're looking at about 3,500 that are associated to non-boating accidents. So whether this is unintentional kiddo falling into the swimming pool, there are a number of different causes for these unintentional drownings. This equates to about 10 deaths per day. When we look at the breakdown of who is drowning, typically 20% are 14 years old or younger. So most of these patients are going to be our pediatric patients or our infant population. So bear in mind that these are going to be pediatric and adolescent patients that are coming in. So 50% of these patients that come into the emergency department are actually hospitalized. So they're either hospitalized or they're transferred to a higher level of care where they're going to be hospitalized and taken care of as well. When we look at other conditions that aren't drowning, this can be as low as 6% of patients that come into the emergency department get hospitalized. So these patients that come in, they are going to be with us more likely than not. A lot of times these patients end up with non-fatal injuries that can lead to or cause severe brain damage and long-term disabilities. So these patients can suffer from memory loss or learning disabilities. They can have even permanent loss of brain function being in a vegetative state. So there's a number of different things that can happen when it comes to these patients that come in with as a drowned victim. This is the third leading cause of unintentional death worldwide. And when we look at across the world, there are about 360,000 drowns per year. So lots of statistics when it comes to epidemiology. Typically, the kiddos are the ones that are a part of the drownings. 20% of them are going to be 14-year-olds or younger, and more than 50% of them are going to be hospitalized.